Okay, let's make a start and then we've got quite a few things to get through tonight. So firstly, I just want to make a really big, huge and heartfelt welcome to everyone who has attended today, and to thank everyone who's been involved in Word Day on behalf of myself and the whole of the Word Day organising committee. So Verily, Wendy, Sammy, Yona and Simon. We've all been really blown away by everyone's contribution to the social media campaign and some of the face-to-face activities that are happening in areas where there's less problems with the pandemic at the moment. We're amazed by the spread of the countries that are involved. So today and throughout the campaign, we've had people involved from South Africa, Egypt, India, Ukraine, Romania, Mexico, Pakistan, Cambodia, Armenia, Kenya, and a whole host of other countries. And we've really been blown away by this. So to start, what I'll ask is just each member of the panel that we've got here today to just introduce themselves briefly. Then we'll move on to a short presentation from Natasha and Saskia around vaccination. And then we'll open up for a question and answer session. And we've got some questions that have been submitted in advance. And we'd also like to invite you all to submit questions using the Q&A at the bottom of your screen. And we'll take questions from the audience after that. Okay, so I'll hand over to each of you. Wendy, do you want to introduce yourself?
Hi, everybody, and you're really welcome. So I am Wendy Costello, and I live in Ireland. I have a daughter with juvenile idiopathic arthritis. Niamh is now 21. She was diagnosed at the age of 3. And when Niamh got her diagnosis, I never wanted any other family to feel the way me and my family felt, alone, scared, nowhere to go for information. We had no paediatric rheumatologists in Ireland at the time. So I really wanted to put an effort into forming a team and supporting families. So I helped set up a charity with some parents called ICAN. And through that, I joined ENCA, which is the European network. And through ENCA, I now chair it, and I sit on the Press Council as a representative for patients and parents. And I am so lucky to work with all these amazing people on this call. And today's Word Day has just, like Eva said, just blown us away. To see a global effort to raise the profile of all paediatric rheumatic diseases is something that we all hold dear. So today has been a really emotional day for us, and this webinar is going to finish off the day lovely. So everybody is welcome. Thank you, Eve.
Thanks, Wendy. Georgie?
Good night to everybody. Thank you very much for inviting me to be here this night. For me, it's a great pleasure to be with friends and families of children with rheumatic diseases. I'm Jordi Antonio. I'm a pediatric rheumatologist at Hospital Sant Joan de Déu in Barcelona, Spain. And I especially interest in education and training. I'm also the chair of the education and training at the Press Council. And I also have been involved as president of the Pediatric Spanish Rheumatic Society, with the work of Spanish Patients and Parents Association. So that has been one of my focus of interest. I think it's key to work with parents and children just to avoid this feeling that Wendy was explaining, to feel alone. I mean, it's not nice to feel alone, and it's not necessary, I think. And activities like today, Word Day, that make people to work closer, it's incredible. I mean, just to see it, it's something that helps your spirit. So thank you very much for organizing it.
Thanks a lot, Jordi. Natasha? Do you want to introduce yourself?
Just Natasha, did you call me? Yes.
Yeah.
Okay. Hello, everybody. My name is Natasha Toplak, and I'm pediatric rheumatologist from Ljubljana, Slovenia. I work at University Children's Hospital, and my main occupation is clinical work with children with rheumatic diseases and, of course, with parents. And this is really a great day that I can take part in this event. One of my main research interests are vaccinations in children with rheumatic diseases, and I'm currently a chair of vaccination working party in Press. This is a very young working party, started only 3 years ago, and we have a lot of work to do also in the future. So I wish everybody a very pleasant evening, and I hope that I will be able to answer some of your questions and to contribute at least a little bit to this great event. Thank you.
Thanks, Natasha. Saskia?
Hi, thank you for having me on this special day of Word Day. My name is Saskia Enjevari. I'm from the Netherlands. I run an organization called KAIS that's more into autoinflammatory diseases. My son is now 15 years old. He was, by birth, he was already sick. Took us about 8 years to discover that he had an autoinflammatory disease. Same as Wendy said, it was a very lonely journey that I had to go through. It refers a little bit to this COVID period because you are locked up, you are alone, and you can't reach out. And I feel this is the same for a lot of children. So thank you for having me here.
Thanks, Saskia. Sammy?
Hi, my name's Sammy Ainsworth. My daughter was diagnosed with lupus when she was 14. She's now 22. From the beginning, I was involved with Lupus UK. They were a great support and a great charity here in the UK. I also got involved with ENCA and have worked with Wendy and Saskia for a number of years. And I have also, for the last 3 years, worked at Alderhay Children's Hospital in Liverpool with Eve and Claire, and I work in the research department, supporting families and young people and their involvement in research, making sure that the voice of families and young people is heard loud and clear in all aspects of clinical research. It's absolutely amazing to be here tonight, really excited about it. It's been a fantastic day, and I hope that you all enjoy the webinar. Good to meet you all.
Thanks, Sammy. Nick?
Hi, I'm Nick Wilkinson. I feel, again, very privileged to be invited to this and hope that we can share a lot of great information. I'm sure we will. So I'm a consultant in paediatric rheumatology and chronic pain, based at the Evelina London's Children's Hospital, which is the other one. It's just across the Thames from the Houses of Parliament, so not a bad view. I was always going to be a paediatric cardiologist from uni, and then I got inspired by a 2-year-old with systemic onset JIA, who at the time, there were no other treatments apart from relentless courses of steroids, and then physiotherapy, bath time for about 2-3 hours before he'd get up in the morning. He had no real services available. And I was lucky that over time, I've been able to close the loop by doing the first research on tocilizumab. Since then, it's all about access to care, responsive care, and working very closely with Children's Chronic Arthritis Association, with NRAS, Versus Arthritis and Lupus UK. And that's a great privilege and an inspiration. And I think our rehab process shows what resilience young people have, you know, in getting back to sport. So we've looked after someone who plays basketball for Northern Ireland, who has played cricket for England, all still with active disease. And that's the inspiration. That's what keeps me going. I think that's what keeps all of us going.
Thanks, Nick. Verily?
Good evening, everyone. I'm Veerle. I live in Belgium. I am a mother to 3 daughters, and my 2 youngest were diagnosed with rheumatic disease when they were teenagers. They have now grown into wonderful young ladies who are 18 and 20, still suffering from their disease, but living life as best as they can. And they are the ones who inspire me to engage myself into representing the voice of young people with rheumatic diseases.
Thanks, Verily. Claire?
Hi, everybody. Sorry, problems with the mute button there. Thanks so much. It's an absolute pleasure to be here today. I'm Claire Payne. I'm a paediatric rheumatologist working at Alderhay Children's Hospital in Liverpool. So I'm a clinical doctor, but I've also got an interest in research and making sure that research is relevant to children, young people and families, and which working closely with Sammy is really key to address. We've also been working with some of the smaller UK charities. So I've got an interest in clinical and research in Behçet's disease and also scleroderma. We work with Behçet's UK and Scleroderma Raynaud's UK just to try and make sure that the voice of children isn't lost in some of the smaller charities as well. So thanks and welcome everyone.
Thanks, Claire. I'm not actually sure if I introduced myself. So my name's Eve Smith. I'm a paediatric rheumatology trainee in Liverpool in the UK. I first got involved in Wordy right at the beginning, and along with Yona sort of came up with the initial idea for it. One of my main clinical interests is in lupus and also in research into lupus. And I'm very involved in the UK GSLE cohort study, which is a national study which collects information on patients with lupus to try and help understand it better. Okay, so let's now hand over to, I think it's Natasha first, to start talking to us a little bit about vaccination.
So thank you for the opportunity to present our working party and to tell you a little bit about our work. So as I already told you, vaccination working party is a very young working party, and it started all in 2019. And what was the reason to create this working party? The reason was that our recommendation for vaccination of children with rheumatic diseases are based on very low level of evidence. So actually there is a need for studies to investigate, of course, the first safety and also immunogenicity and also long-term efficacy. So at first we needed to create a platform of the countries that would participate. So we collected the data about the vaccination practices in 25 countries, and we came up with very interesting results. There were a lot of differences in the vaccination programs in different countries, also difference about the obligation of parents to vaccinate their children. And then the next step was to identify problems in children with rheumatic diseases concerning about vaccination. So first we need to ask ourselves, are infections a problem in children with rheumatic diseases who are treated with immunosuppressive drugs? And we know that this is the problem because the main adverse events of the drugs that we use in these children are infections. So vaccinations are definitely the most effective measure to prevent infections. So these children should be even more vaccinated than healthy children, right? But the other problem that we identified is very low level of vaccine coverage in children with rheumatic diseases. And then we went further and we did a study about the attitude of pediatric rheumatologists towards vaccination. And we came up with very interesting results. Only about 50% of pediatric rheumatologists are advising vaccination and checking vaccine status and coverage at the outpatient office regularly. About 20 to 30% of doctors are checking this sometimes, and about 10% don't even check about the vaccination, and they don't advise these patients to take vaccines. And of course, a big problem is also about the hesitancy of parents to vaccinate their children. Me as a mother, I can understand this reluctance to vaccinate. Of course, parents, we are afraid that vaccines might cause some side effects. And of course, there is a question about the disease activity, which might get worse after the vaccination. And of course, about the issue of efficacy. So there are many problems that we need to address. And of course, the main problem still in the question of vaccine safety and efficacy lies in the field of live attenuated vaccines. We have quite a lot of data also from adults and also from children that non-live vaccines are safe and they are also effective also in children treated with biologic therapy. But what about live attenuated vaccines? The data are really, really limited. So the vaccination working party started with a bit big project 2 years ago to collect the data about the booster dose of MMR vaccine in children who are treated with immunosuppressive drugs. And the data were collected from 9 countries because a lot of rheumatologists were convinced that it's much safer to vaccinate children than to expose them to live wild-type virus. So we collected over 250 children who were vaccinated with the second dose of MMR vaccine while they were treated with immunosuppressive drugs. And over 100 of them were treated with biologic therapy. And the results were that the vaccine was completely safe. Because this was a retrospective study, we didn't check the immunogenicity, but this is now one of the major tasks for the future, to do a prospective study. And of course, now there is, in this time of pandemics of coronavirus, there is a question, do we need to vaccinate children with rheumatic diseases who are treated with immunosuppressive therapy against against SARS-CoV-2 virus? First, we have to ask ourselves, are our children that are treated with the drugs in danger because of coronavirus? We are still collecting the data, but I can tell you the data from my center. So far, we have more than 20 patients on immunosuppressive therapy that were in contact with COVID infection. The majority of them had no science because we only knew that they got the infection because the parents got it. And majority of them had no science, but we checked serology. So in more than 20 of them, serology was positive. Only few of them had few science, and more than 10 were treated with biologic therapy. But still, we know that especially in patients, for example, lupus patients, where many organs are affected, not just joints, this disease can be severe. So there is a question about vaccination. But for now, there is a big problem because no vaccine is officially recognized for vaccination over the age of 16. Only BioNTech vaccine has the age limit of 16, but all other vaccines has the lower age 18. So for now, no vaccine can be used in children. So we are just waiting that this will change, and then we will need to check the safety and efficacy of these vaccines in our children. I'm looking forward to your questions. I hope I will be able to clarify some of your concerns. So I will finish with this and go to Saskia. Thank you very much.
Thank you, Natasha. I won't go to all the deeps about vaccination and why it's important to vaccinate or not. I just wanted to clarify a little bit more what the involvement is of patients advocates in the working group of vaccination. I think we all think that patient involvement in work groups, research, and better understanding of the disease is a way to success, because it contains information for both parties, using simple steps and advice, and it shows how everyone can improve with their collaboration. It will improve results for projects. It will lead to a better result of the patient. That's also the reason where we as ENCA and other European patient organizations work together. And we did a survey 2 years ago, 2019, and went into 2020. And the survey was a vaccination survey because we wanted to understand what is the need of the patients and their families to understand the reason of to vaccinate or not to vaccinate. Our work on importance of the vaccination for patients with chronic conditions is still processing, specifically aiming on to provide information and research for patient organizations to support their advocacy on vaccination. What we clearly saw was that the information from the physicians to the patients is not really clear. They have still a lot of questions. They have questions about, do I get into a flare? A lot of patients and patients' family represented that they had a vaccination and they went into a flare. They were afraid for the next vaccination. So clearly that lack of information needs to be better and understanding. Especially patients and their family are afraid for getting into a flare. It should be not the reject of a vaccination to get vaccinated. But we also saw that there was a lot of information out there on internet, but not always all the information were clear. It was not understandable. It was a lot of information that was hard to get or hard to understand. But also the difference in Europe, in countries, is unbelievable. Some of the information are very clear in English, but in other countries who don't have that access, they didn't have that information. I think especially for us, for the Working Party, because I work together with Natasha, I think it's better to collaborate with each other and make clear that the information that we are getting out, it's clear for the patients and that they can ask the questions and maybe also think about the questions that they want to have as answers. I think a strong patient voice drives a better health in Europe. Thank you.
Thanks a lot, Saskia and Natasha, for your talk. So now it's time to open up to questions. Verily and I will be taking questions from the Q&A. So for those of you who missed it at the beginning, if you can just ask questions in the chat. We've had some that were submitted in advance, which we can start with. But if you have any questions that you'd like answered, either based on those talks or really on anything that you'd like to ask to the panel, then just put them in the Q&A. Verily, do you want to start with a question?
Yeah, sure. You know, from a parent perspective, what I would like to hear from the rheumatologists is, you know, when first being diagnosed, as a parent, you wonder, what trajectory am I stepping into? Because typically you would expect, well, the doctor's going to give me a prescription and my child is going to feel better. And they soon realize that that is not the case. So what can parents expect?
I'll come in, Bill, if that's okay. So I think this is one of the hardest things that when we're talking to families and children and young people in clinic, is that uncertainty of what's going to happen with the diagnosis course. And I've got a lot of patients that actually are really nervous coming to see you because they've, for example, some of our JIA patients, they feel okay, and you may find a joint when you examine them, and they're quite anxious about that. There is quite a lot of work that we're trying to do to try and tell us more about what will happen in terms of the courses for children and young people, but we haven't got all the research or the answers yet. But I think it's a particular area that's really important for families, and working out how we support that. And I think some of the links to peer support and other patient groups are key to help support families through that.
Thank you.
Can I just jump in and just add is that we don't know, but one of the important thing is to build rapport. And what we find is that what we want to do is help parents in their journey. They want questions right at the start, and we can't always give all of those. But if you build rapport and you're free and accessible to answer the questions as they go along, then there's trust. And then you're working towards a good outcome. So you're not working necessarily just to control the joints. What you're doing is you're working to optimize quality of life and ultimately independence and future. And if the parent understands that that's your prime aim at the start, then you work together. And I think that's a really important thing, rather than just saying, look, we've got the fix, because clearly in many cases we don't. But it doesn't mean to say that everybody can't go on to really valuable, independent lives.
Thanks, Nick and Claire. Verily, I'll just ask a question that can be perceived as big or as small as you like. So this is a question that came in advance of the meeting. So what do you see as being the next steps in the treatment of juvenile rheumatic diseases?
I think
I'm sorry, Claire. I was just going to say that just from my point of view, when Niamh was diagnosed and all we had was steroids and methotrexate, how things have changed hugely over the last 20 years, hugely. So I can imagine what the next 20 years is going to bring. But from a parent point of view, it's great to see so many different options, and also being able to find the subtype makes a huge difference to the treatment options now. And as Nick said, there's a conversation now, a two-way conversation that probably was never had before, where it was just A, B, C, tick the boxes, move on to the next one. Whereas now you definitely have lots of more options. But I know everybody, maybe Jordi can talk about JAK inhibitors and different IL-1s and IL-6s now that are coming along, and how interesting that is.
Yeah, I mean, I think the future is a lot brighter than was in the past years. I mean, as Nick said, I remind when at the beginning of working in my current hospital, there still was this swimming pool to put kids in warm water just to feel better. And there were kids in cranes and in wheelchairs. And now that's almost gone for everybody, you know, and we just removed this swimming pool. And there are new treatments arriving. And of course, sometimes we have some delay with, and we know what is coming on because we know what the others were. The new drugs are tested before in advance, and probably they will work. And our armamentarium it's increasing day by day. So I think that's important, and that will change our way. But related with the question that was before, I think that we, at the same time we are working in new drugs, we must work more in how parents and children and young adolescents feel, not just checking their joint counts, if we talk about arthritis or other diseases, and focuses more on how they, which is their feelings about their own disease, no? And giving tools to confront the disease and to come back to a normal life. So I think it's both sides, that sometimes we as doctors, we are just focused on joint counts and blood tests and not profiling how the patient is feeling, or how the family is living the experience. I think it's also important. And I think we have to develop more, and there are works done in that too.
Can I just say, I from sort of my role and also my experience as a mum, crucially, I think going back to what Nick said about being in a relationship and building that relationship and that trust from the beginning is all linked to this, because now I really hope that sort of together it's a partnership. So it's the clinicians with all of their huge expertise, it's all the researchers with all of theirs, and then it's the families, and we're all sort of part of a picture now. So hopefully everybody's voice is being heard as these new drugs and these new medications are going forward, and it's definitely going to be a three-way partnership, and all based on communication and trust. That's my hope for the future anyway. Not much.
There is another important issue here. I think we need to recognize this disease very fast. Because in some countries, I mean, there are still no pediatric rheumatologists, and children are going around, as Saskia said, I mean, for many years before this disease is recognized. If we start to treat early and we treat aggressively with these new drugs, we can prevent long-term disability and chronic joint destruction. So education is very important. Students at the university and also pediatric residents and also family doctors, we need to educate. And this is also one important step in the future that we need to take.
I think that highlights really nicely the importance of Word Day, Natasha, actually, is awareness among doctors and healthcare professionals, but also parents and families to help empower them to get the help that they need as well. I think one of the other issues that we've had, as we said, it's been really exciting with a whole lot of new drugs. Being able to choose the right drug for the right child at the right time, I think, is something we need to work towards in the future. The other thing I don't think we've got right yet is being able to manage pain and fatigue. And I think by working together with families, but also with the wider team, so with our physios, our occupational therapists and our psychologists, I think that's areas we need to work at as well.
Let me pick up on that, because fatigue is one of the most debilitating factors that our young people are reporting. So how do you see the future of managing fatigue?
So I think it's something we still haven't got all the answers to. So I don't think we fully understand the mechanisms behind fatigue. So we know that inflammation can cause fatigue, but even when we've turned off inflammation from the tests that we can do in terms of examining patients, blood tests, scans, a lot of patients still struggle with fatigue. And I think understanding why that is, we still need to do some work in terms of research, but also thinking about strategies to how we improve that. And I think looking at that in terms of with our wider teams, I think is key, and possibly learning from other disease areas as well. Fatigue's a problem across a lot of chronic diseases, not just rheumatic, and it's the same. I think it's the same in adults, and it's just an area we don't fully understand. I don't know if anyone else can give a better. Nick's got his hand up.
So we, as in setting up a chronic pain service, we've learned a lot from that, and there is lots of really fantastic research, and unfortunately it is impossible to talk about all of that today because of the science behind it is really complex. But I can tell you that we have enormous benefit and effect through our multidisciplinary team in the way that we explain about pain and explain about fatigue. We don't actually in our service now manage an awful lot of that, and because of the approach that we have right from the start. And so understanding, I think, is one of the key factors of families. And so a lot of focus on the first 9 months, and then about 6 months, and then about creating opportunity and thinking about function and participation often is much more important than focusing on the pain and the fatigue. And that then changes the mechanism, changes the response, and the outcome of these patients.
Yeah, I think I hear where you're coming from. One of our teenagers recently said to me, well, beforehand I was thinking being sick is a full-time job.
Yeah.
And when she started managing her energy, she says, well, being healthy is a part-time job because I put in that much effort into being able to live my life the way I want to.
Beautifully put, beautifully put. Essentially what we want is because the condition for many people is out here in front of them, and it's what in some ways defines young people. And what we want is it's behind, and so they just think about the opportunities ahead and not what's going to slow them up. It's one approach, and obviously we've got lots to do in working with young people to optimize everybody's quality of life.
Mm.
Nick, just to pick up on that, one of the questions that's just appeared in the chat is, so how do we get systems that Nick is speaking about rolled out to other centres? So I know you've been involved a lot in developing services and obviously developing your pain and fatigue service. So for people who are participating, who are maybe from small centres, who maybe don't have an MDT around them, what would be your advice?
So I think it's communities of practice. Some of this will be from research, but some of it is from just going to see other centres and then being inspired to work in different ways and then taking it back to your centre. So we'll be, we have lots of other centres that come to visit us, especially around pain and fatigue, but we would welcome anybody, and we would welcome, we would provide virtual teaching. But I think it's up to everybody just to engage in a different approach and think about things in a different way. I think that's often quite enabling. Yeah, I'd be inspired.
And if all else fails, Nick, we'll just have to clone you.
Can I just come back to one thing, which we're talking, and it was really well brought up by Natasha, I think it was, about access through the rest of the world. And I think one of the challenges now is we're very privileged, obviously in Western Europe, to the access to care. And one of the things that's really pleased me is the drop in cost of some of the drugs. You know, we're looking at 10 grand a year, British pounds. And now we've got, the new biosimilars that are coming down to about £1.5 grand. Now that's still an awful lot of money. And so these are all coming down in cost. And we need to be finding ways of helping elsewhere access these drugs, and not just the methotrexate. We want to have alternatives to the methotrexate. And so I think we are as beholden not to think about just our own populations, but also how do we work worldwide. And so people like, Christian Scott in South Africa, and what he's doing with South America and Africa is amazing, and it's happening elsewhere too. And we need to provide that level of support.
How can we help from Word Day out? I mean, I've been getting a lot of feedback recently, on not enough rheumatologists for children, not enough medication. So we from Word Day, we'd like to be involved in helping in that regard. Absolutely. And speaking of methotrexate, for many children, the burden of a treatment is huge, especially for little ones. And how do you see that moving forward? How do we deal with it? Is there a way where one day we might even be able to put that behind us? Do you think?
So the burden of medication is associated with the burden of disease. And first of all, medication just reminds us that we've got the condition. And so that then is already a challenge. You can get side effects from placebo. So we need to understand, well, why does that occur? But again, and then we've got methotrexate, which I think in all adolescents is just considered the worst ever drug. I don't know an adolescent who doesn't hate the thing, but it can be effective, and it can be very effective for the little ones. But so it's alternatives, it's working with different approaches to medication, different routes of medication. So I think, again, there's so much that we can do.
I must say that there are some things curious with methotrexate, and it's fascinating how, if we compare other groups of patients that take methotrexate, like those with leukemia, sometimes they don't have so much side effects like patients with juvenile idiopathic arthritis. So we still don't know everything about methotrexate, in spite this is the most used drug and one of the most effective drugs we use in pediatric rheumatology. Yeah. The good news is that, as we have said, there are new drugs that can help with those patients that cannot are not doing well with methotrexate or can use it. No, and coming back about what you were saying, really, about the role of patients and linking with Natasha and Nick Wilkinson, I think associations have a huge role in those parts of the world, also in Western world, to help to promote training in pediatric rheumatology, also associations, and the possibilities to provide the care of, for example, Nick Wilkinson was commenting, because in other countries it's not so easy to treat not only drugs and methotrexate, biologics, but also all of these other side aspects that sometimes are just not considered by the health system.
The care on top of
we
the
have
cure.
Comments of families are in the chat saying that there are countries with only a few pediatric rheumatologists. So it's still this work of association that is very needed, and this day is great to make the awareness for that.
Okay, so just to pick up on another question in the chat, trying and failing each drug is a long process. Are there blood tests that can be done to help predetermine which drug would be most suitable? I see in America that sometimes you look at biomarkers to guide drug choice. Are these tests available in the UK? Working our way through each drug takes such a long time. My son is systemic GIA.
So, as far as I'm aware, at the moment, we don't, in paediatric rheumatology, we don't have very good ways of choosing the right drug. There are some types of arthritis, for example, systemic, where we may choose some drugs over others, but it is an area that we're working up to try and be able to, as I said, match the right drug to the right child early on, because it's really difficult and frustrating to go through drugs and also then to fail a new drug. So it's something we haven't got right yet, but I don't know if the rest of the panel want to comment.
Can I add something on that? Especially from a view as a mom. My son, of course, has an autoinflammatory disease. It took 8 years to discover that. That was already a long time of diagnosed. He's 15 years old now, and we still haven't have the right drug. So, I mean, you will be so happy to receive a diagnosis, but as a parent and as a patient too, a child doesn't understand that there is also going to be maybe a long time to find the right medication. And it's a shame that nobody discussed that with us back then in the office. And I think this is also, you go into an office, you find a diagnosis, you are happy with it, you find the right specialist also, so you are in a hallelujah, and then you are still waiting for that right drugs. So yeah, it's a trial and error, and you are picking it up and you take it in your backpack and you go on again. But it's always a damage into the family also.
Now, one of the things that parents typically start thinking is, they want to take control. And one of the questions that we get a lot is there anything we can do with regards to dietary changes or dietary supplements? And that's a very difficult one, I think. So I'd like to have some medical background to, staff that response.
I may try to respond. I already wrote some answers in the chat. So far, there are no evidence that any kind of diet would help with chronic arthritis. I mean, if you have an open discussion with the parent, and I mean, it's a good way to do it. I mean, to discuss all options. I don't have a problem if parents want to try something, but as long as they agree to treat chronic arthritis. As I said, we need to treat early, so I would not postpone a medical treatment because you want to try the diet. You can combine it if you think it's okay, it's no problem, but still we have to keep in mind that the child is growing. So some diets can be harmful, if you go only to vegan diet, I mean, the child that grows needs proteins. So I don't have a problem if you put white sugar out of your food or if you put pork out of your table, but some diets can also be dangerous. And we have to discuss this openly. But so far, there are no evidence that only diet would help to treat the chronic arthritis.
So a normal healthy lifestyle is more appropriate.
Exactly. Normal healthy lifestyle, healthy food, Mediterranean food, Italian olives, fresh fruits.
Is that with the red wine?
Well,
not for children.
But, for the panelists, for now, I would love to serve you some red wine. Slovenia is very near Italy, near Tuscany, so Chianti would do fine.
Now, a question that fits into that. Many parents also ask.
Yeah, if I can add just something about that, it's important. At the end, parents decide to try something. Communicate with your doctor, because sometimes we face problems and we don't understand. And still, one of the most frequent when we as doctors work of no response to a treatment is that the patient doesn't trust the treatment and is not taking it, or because he's taking other diets, special diets that can interfere with the treatment. So it's important, and sometimes related to what we could talk at the beginning, to have trust with your team, to feel comfortable to manifest, to express your doubts, and just build a common treatment pathway all together, no? Because if not, we are not in the same side.
Yeah, exactly.
Just wanted to add that, sorry.
Absolutely.
Can I just say, oh, sorry, go on.
Oh, Sammy, go ahead.
I'm just going to say, as a mum, I remember when Sophie was diagnosed, it seemed that every family or large function we attended, somebody was there to tell us an amazing dietary thing that would change the outlook of Sophie's lupus.
Mm-hmm.
And so very soon as a mum, I realized that we were going to actually listen to the clinicians. We were going to use some common sense. We were going to smile nicely to the person who gave us these huge words of wisdom. And then we were just going to go away and just try and keep things nice and calm. I didn't want the whole diet issue to become another burden for Sophie as she was becoming used to all these medications, all these changes in her life, and actually getting her head around a diagnosis. So all the way along, I think it's just been a bit about common sense, talking to clinicians, like Geordie's just said, and just working out what is right for you and not beating yourself up too much about anything.
Yeah, exactly. Like, you know, people saying, well, you should boost your immune system. And as a parent, you're like, no, this is not the way. Or hopefully you say, well, hold off your horses. The doctors know what they're doing.
Can I just add, you see, I think it's much more powerful coming from you as parents, as part of these societies and support groups you set up, because as doctors, sometimes we're seen as being complicit with entirely Western care, and that we don't have an open mind to other approaches to therapies. And so I think it's really important as parents that you feel confident in talking about this with other parents. Mm-hmm. And I can just point you to a fantastic resource for Versus Arthritis, who have a really good resource on complementary therapies. And so I often point parents to that, because again, it's another charity that can talk about, well, what is the role of various herbal medicines, and they provide some really sensible advice and balanced opinion about potential for side effects, because even herbs have side effects compared to, you know, and we can just think of colchicine, which is from the crocus, you know, and it causes the squits. But, you know, if no one would talk about that if it was just a herbal remedy.
Thank you.
Thanks, everyone. There's a question that came through through the before not in the question and answer, but about conducting research in lower and middle income countries. Does anybody on the panel have any advice to people setting up, you know, research into pediatric rheumatic disease in those types of countries?
I might try to answer this. I mean, there is still a big difference between the West and the East, and because in the means of financial restrictions, right? So the basic studies, you need a good lab, you need a lot of knowledge, and you need money. So for the basic study, I think we will never catch, or Eastern countries will have some very hard time to catch Western countries. But there are a lot of clinical things that need to be investigated, especially in the field of vaccinations, to see what is the attitude of parents and children towards certain measures that we use towards the disease, and to see the clinical outcomes on a long term. Also to study immunogenicity, you don't need a lot of financial support for this. So there are a lot of things that you can also do with a very low budget. You just need to go for it. You just need to have, you know, a lot of will to overcome some obstacles. Like in vaccination, the biggest obstacle is ethical committee approval. But there is the way to do it. I mean, and you can also do it with little money.
Can I just... So I know I know that, for example, one of my colleague and friend in the UK, Professor Ramanan at Bristol, has been working with paediatric rheumatologists in India to try and work and get clinical trials coming there, and they particularly had some success around looking at some of the conditions around COVID and inflammation. But I think we've also got responsibilities as researchers in the West to think about low-cost medications, a bit like what Nick mentioned before. But there are some studies that we can be doing, thinking about the cost of medicine and using low-cost medicines. So, for example, in Kawasaki's disease, immunoglobulin can be really expensive. If we had some studies proving more around steroid use, then that might be more accessible to countries that struggle to get hold of more expensive medications.
Can I ask, do you think that patients' organizations are also being involved in that to have more reach out in those countries? Do you think they are a good access to go from there?
Definitely, yeah. I think the patient voice is always is really, really helpful and can really push some of these agendas as well.
So even that is maybe a much easier step to take for those countries to set up a patient organization and at least go from there to broader or wider the future on access to medication or healthcare or information.
I think taking advantage of infrastructure like things like the Press Emerge Fellowship or the EULAR Fellowships, where you can, go to a different country and maybe do some research alongside clinical work and then maybe bring that back to your country, or, exchanges like that. I was involved in some research with Chris Scott in South Africa. And he already had an established lupus cohort, but he didn't have mechanisms around collecting samples for things that we were doing in the lab. So I helped to support. I'd got a grant at the time and helped to pay for some of the costs for one of Chris's research nurses. So although that research nurse was working on my stuff, she was also working on a whole range of other things with Chris. So it really helped Chris in his research as well. So I think building relationships like that can help both ways, really.
We've got quite some questions on when can we expect our child to reach remission or full recovery? Are there percentages? That's what people are, wondering. Because some children overgrow it, but some is rather not tangible. So
okay, that's a tough question. It depends on the disease. It depends of the moment of which the treatment is started. It depends on the response. What we can say is that generally we work with figures and we can talk about percentage, and those percentages also are changing because it's not the same to analyze nowadays young adults of 20 to 30 that had a disease when they were 2 years old. That means 20 years old before the starting of biologics. That talking about those who are arriving to this age and have been have the possibility to be treated with new drugs. So for us, it's difficult. Also, there are nice work, some of them coming from the North European countries, Scandinavian countries, where we have a nice cohorts of group of patients or of other countries. And in some diseases, we can say 70% of patients at age are in remission, or 60%, but it's very difficult to just go to be concrete, to be specific with one type of disease or one group. No, that's another thing that one must be discussed with families, and which are the possibilities, and what we can know is which factors promote a better response or a bad response, and that are easily identified. And in some diseases, we can have some markers that can help us, no? But it's not that we can just simplify to say when your child will arrive after puberty, or when you go to adult, you will be fine. That's not real, and I think we must be clear about that. If not, it's wishful thinking.
So again, families should not be afraid to discuss that question with their doctor. Yeah.
I was also going to say too that when families contact me, and obviously they're very anxious to know what will help and when their child will reach remission, that there is no magic pill out there. And I try to tell this to everybody. It's not just the medication on its own. And I know this is something that we were going to bring up and talk about, that how important it is to have that multidisciplinary approach. You need your physiotherapy, you need your occupational therapist. It's everybody working together. And I can't stress how important physiotherapy is in the journey of your child. And it's made a big difference in my daughter's life, not only to her disease, but also mentally to her outlook in life. Her physio has made a huge, huge difference.
Sounds familiar. So, how do you approach parents who are anxious to, well, to have their child engage in physical activity? Because parents might have the urge to protect their child from overexertion, for instance. So how do you approach that when you notice that in a parent?
So,
If I may tell you, Mike, sorry.
Go ahead, Natasha.
No, I just wanted to share with you my experience. When I started in pediatric rheumatology more than 15 years ago, I came across children that were having, some special papers that excuse them from physical activity. So they shouldn't do physical activity. Nowadays, we know that physical activity is one important part of the treatment, because we need to keep our muscles fit and we need to keep our joints in good condition. So I do advise moderate physical activity, but I do say to my children, please don't go to Olympics or to the World Championship, because this is really stressful even for completely healthy children. And I don't really want you to do too much exercise. I can say that majority of families are very open to this, but children, when they come to puberty, they have many problems, and some of them, they don't want to do physical activity, so they come back and they say to me that they have pains and there is no active arthritis. And what I found very difficult is how to treat a child with diagnosis of juvenile idiopathic arthritis and with a chronic pain. This is very challenging for me, but I think to promote physical activity is the best way to go, and to offer support to this family also in a psychological way.
I was just going to mention that the best available evidence for this is in osteoarthritis in those who are retired. And what we know is that joints crumble quicker if you don't do any activity. And actually, if you're physically active, you're walking, you're gardening, everything like this, in the 60 and 70-year-olds, you preserve your joints. And that's because you then maintain the right tissue structures, the muscles, to support the joints. It also helps then with resilience when it comes to getting a flare. We can't promise that there won't be a flare. And we know that we lose muscle strength very, very quickly in everyone who becomes sedentary, even for a short while. And so if you then have an inflammatory condition on top of that, the loss of muscle is quite quick. So you have to keep physically active to return all of those muscles. And actually, I wouldn't inhibit anybody by anything that I say, because young people will find their own way. So why would I put a barrier in their place? And so I talk about, if they want to run the world record, then I will do my best to control their condition so that they could begin to train for that. Because it's all about training. I'm not telling them just to hop on and do it straight off. It is all about just building up and working towards what your goals are. But don't limit yourself.
If I might just summarize, physical exercise is also must be prescribed to these patients. Like we prescribe a drug, we must prescribe it. It's good for health, it's good for their joints, and it's also good for them, for their mental health, to play with their friends, with colleagues. It's to see the patient not only for their joints as a whole.
Thank you.
And I'd just like to add, there's no one more inspiring than Serena Williams. She has lupus.
Yeah.
Didn't realise that.
Can I just say too that we're very lucky in Ireland. If anybody follows rugby, which I don't follow rugby, but we have a player from New Zealand playing for Leinster in Ireland at the moment called James Lowe, and James has JIA since he was a child, and he's been on biologics, Humira, Enbrel. He's off biologics, controls with anti-inflammatories, and he has come to some of our events, and the kids just think this is amazing that a world rugby star has JIA. And you know what? Kids need to see that.
Yeah.
They so need to see that. Not kids are, all kids are into sports. So James is just an example, but it's, you know, when he speaks about lying in a bed crippled, his dad had to lift him into the bath crying. Those were his young days, and how he built himself back up, did his physio, took his medications, and now is an international rugby star. And you're right, Nick, you know, our kids can achieve whatever they want to achieve, how small or how big.
Yep.
Let them dream big.
Definitely.
There's some comments in the chat about England netballer with GIA, and also Debbie Wilson. So she's got GIA, and daughter also has GIA, and they've recently climbed Snowdon. So definitely aiming big is a good idea. Just one of the questions: experiences of getting a diagnosis. What are children and parents' main concerns? So to hear really from Wendy, Sammy, and Verily, what are the main concerns when getting a diagnosis? And Saskia, sorry, as well. If you can think back.
So I remember asking Niamh, I had a conversation with her when she was about 13 or 14, and she kind of realised that her life was different, because all along she thought all the kids had pains in their ankles and knees like she did. She didn't think she was any different to anybody. And I remember having a conversation about what her life was going to be like, and she turned to me and she said, all I remember about being diagnosed is that you kept crying all the time. And I probably did. I probably cried for the first 2 years while I tried to get my head around how our life had changed. But all the questions I had on the first couple of appointments, just, you know, I just couldn't get them out. I just had to let the pediatric rheumatologist tell me what was happening, put her on medication. And it's really only a year or two into a diagnosis, I think you as a parent sit down, take the information in and start to look ahead. You're only living in the moment for that first year or two while you with trial and error drugs and physio and uveitis, and it's just, there's so much thrown at you with JIA, and I'm sure it's the same it's even harder for autoinflammatory because it takes so long to get a diagnosis. At least in JIA you'll get a diagnosis in 2 or 3 years, but I know for me it was to sit down and to ring a charity, or in my case to start a charity and meet other parents, and it's through them you start to realise that you're not on your own. And I think that's really important. And for us in Ireland, we have rheumatology nurses. I know some countries are not lucky to have nurses. I think they're the key to a lot of the families as well. If the clinician has only got 10 minutes with a family, you're not going to cover a lot. But when you come out and speak to the rheumatology nurse, you can ask them loads of questions. You can email them afterwards. You can call them day or night. And I think they're the link as the child gets older and transitions into adult services as well. So I'm a huge advocate for rheumatology nurses. I think they do an amazing job.
Absolutely.
For me, it was, my son was sick at 6 weeks old. His birth card was still up in the hospital's walls when he got back admitted. I think the first 8 years, I went from one doctor to another. I did the craziest things, like put a pill on a golden spoon and had to circle around because they said that was the solution. Nobody knew, of course, what he was having, but he was hospitalized like every month. at least for 8 years. I gave up. I really gave up. I was done with searching and looking for a specialist. And I had a good pediatrician back then in the US. And I cried and I said, you know, I'm done. This is how our life will be. Okay, fine with that, because I can't put it up anymore. And actually, she said, I have one different person you can go to. And I went in, and that person, she's from the US, Dr. Lepidus. She said she disconnected all her appointments. And she said, I think I know what is wrong with him. And she did genetic tests right away. And 2 weeks after that, I still remember I was driving to the appointment, and we got a diagnosis. But those 8 years of my life, my family life, and also from my son was horrible, because I didn't have no one to turn to, because I didn't know what was wrong. I had no answer back then, and I was so lonely.
And
that's
you're
why
so alone.
And that's why the reason why I am a patient advocate at this point, because I don't want to have other patients going through the same journey that I have. And I think at least we are now in 2021. We are more connected with each other. We are understanding more. And I think the diagnosis time is less than, for me, 15 years ago. But it's a horrible feeling.
Yeah, it's that feeling of being alone when you don't know what's wrong. My daughter was sick for 9 years before we knew that it was an autoimmune disease, and it took another 2 years before they put the label lupus on it. And by that time, she was bedridden, which was awful, because as long as we didn't know what was wrong, it was almost like it was in my head, and I wanted my child to be sick. And all the time, she just kept soldiering on, not being well, but still wanting to live her life, not being able to. So getting the diagnosis finally was such a relief, even though I knew that that was not the end game, that it was just the start of another road. But at least I knew, or we knew, where we were going towards recovery and towards her finding a way to live her life.
I think for me, I always remember I carried Sophie into Alderhay. She could barely walk the day that we finally had the appointment. And Claire might not remember, but Claire was the first clinician, long before she was a colleague. Claire was the first doctor who looked after my daughter. And I think the day we very quickly got a diagnosis, thanks to the team at Alderhay. And whilst, like Wendy, I was sat there in floods of tears, Sophie was passing the tissues to me. And Mum, it's going to be okay. We know, you know, it's going to be okay. And there was a feeling, whilst I was definitely in shock, there was also a feeling of relief that we had a diagnosis, we knew what we was dealing with, and it was like, I'm a control freak. So it was like, right, now, what is the plan? Like Verly said earlier on, we like to be in control. We like to, right, what do we do now? And it took a couple of years really for me to probably fall to pieces when I realised that I'd forgotten a really sort of important part of the jigsaw, and that was that I had to keep myself well to be able to support my daughter. And talking to other parents and being involved in charities and feeling that support you get, like Saskia's taught and Wendy's taught from other parents, support we've all given each other, just means the world. It means absolutely everything. And from that, we then learn how to empower our kids, because whilst we support our kids and we get them through those first early days of diagnosis and learning all about their condition and about their medication, ultimately it's our role to then empower our kids, to give them the skills to carry this through the rest of their life. And I think we can only do that if we all become a team and we all learn to talk to each other and we reach out to our charities and we become a partnership with the clinicians. And we've all got a huge part to play. But I absolutely think the day that I rang Lupus UK, that was a life-changing moment for me. The day that I picked the phone up and basically just said help to somebody at Lupus UK, and she's still a very, very, very dear friend now. And that's why I got so involved with the charity that means the absolute world to me. And then people like Enka, people, you know, that I'm sat looking at on this screen, and beyond, you get your army behind you and you just fight for your kids. And thankfully, we've got great clinicians like yourselves doing that for us as well.
Thanks, Sammy, Wendy and Verily. It's all very powerful, your stories. We've got probably a couple of minutes left. We've already gone over, but we said we would probably go on till about 1:15. I want to ask a question about Down's arthritis, because I think there's someone that's really keen to ask a question. So do the panel know if there's any centres of excellence for treating Down's arthritis, the best treatments, and any good resources out there around Down's arthritis?
I'll start just by saying that we have a wonderful researcher. She's not in Ireland anymore. She's gone back to England, but Charlene Foley, if anybody wants to look her up. So she did a research project on Down's arthritis, and this is where it started a couple of years ago, which is amazing. And what she did was she put a call out to Down Syndrome Ireland, and if you had a child with Down syndrome, you came, she examined them, and she picked up so many kids that had JIA with Down syndrome. It was absolutely amazing. So if anybody wants to look up Charlene Foley's work, and I know the team in Crumlin Children's Hospital have done a lot of work in this, so if anyone wants to connect to Dr. Orla Killeen as well, I know she's done some work around this. So that's what I know from my point of view.
I think we'd all consider Dublin to be the place to go for Down's arthritis. I think it's exceptional what you guys have done.
In terms of the best treatments, what from your experience would you say?
With my limited experience, methotrexate worked perfectly in majority of my patients, but I know that a lot of patients with Down syndrome and arthritis do not respond to this first DMARD, and based on immunology of this disease, I think the JAK inhibitors could be the solution for these patients, but it's a problem because these drugs are not licensed for children. But as far as I know, we haven't tried it yet in our patients, but because there is interferon pathway that is disturbed in Down syndrome, JAK inhibitors are probably a promising drug when they will be registered for children, licensed for children. I don't know, Jordi or Nick will have some data on this.
I mean, in our experience, what there is this spectrum of patients with Down syndrome and arthritis, and we have seen some of them that are like other kids with JIA, and there are others that have a more severe disease, and with it's harder to control. And besides that, there is some of these patients have some degree of immunodeficiency that make it harder to use something. So it's true. It's in our experience, it's not like other arthritis, and deserves a more accurate work with these patients. I mean, if without knowing the details of any patient, it's difficult to be more precise. But still, there are options for sure for these patients, and there is nice work that has been done, that has been mentioned.
So I'm gonna close off with one last question. As a doctor, how do you feel about the shared decision-making process with regards to children and young people? Because you've got in your room, you've got the parents, you've got the patients, and you yourself as a doctor. And of course, you as a doctor, you know you're in the driving seat because you know where you're going or where you're supposed to go. But how do you give a voice to both the parents and the patients themselves?
So to fill the void, it is the only way. There is no other way. It has to be a shared decision. And in fact, no, it's the young person's decision. And so that's all about information sharing. So if we're sharing information effectively, then the young people and the parents can make their own decision, because we cannot be so definitive about it. And it's about the comprehensive approach, which I think we've covered beautifully today from everybody. So it's not just about the drugs, it's about everything else. But it's a shared language, it's a shared conversation, understanding that at the center of it all is the young person, and they have a voice. I don't know, I hope that answers your question.
And that's where transition is just so important to get right and start from an early age to give that child a voice. Because sometimes as parents, we've got to be told back off, go out of the room. You know, you've been speaking for this child since they were 2, but I can't, you know, I can't encourage parents enough to let that child speak up from a very young age. I've met children at 14 or 15 at events who didn't even know the name of their disease or what they had, because they just left all that to their parent. So that's transition will not work in that situation, and moving to an adult service is hard enough if that child doesn't have a voice. So I think it's very important for parents to encourage that.
And I agree with you, but as we are here today, and this is World Day, and there are people probably connecting from all the world, I think that we must also think that the cultural difference that we also have all over the world, and the different setup and how we work. And I think doctors, and that's the key thing, it's must all the time unlearn some of the ways we used to approach patients, and be open to approach in a new way in when we work together to take decisions. No, and this is something that must be constantly done. It doesn't depend that you are a new generation or just trained doctors or new residents. Constantly, you must avoid to know, well, that's what I know, that's what must be done. And sometimes it's also uncomfortable, I must recognize for ourselves, because you see, well, this is a treatment, and you don't succeed convincing the family, and it's something that you must recognize. For us, it's difficult too. So that's the reason because I say unlearn, because you can feel like you are failing because you are not succeeding to convince this family, no? So it's an important issue, and I think we must all the time work on it. We as doctors and families and patients, especially adolescents when they are starting transition, because it's the only way, as Nick can say, but it's not an easy way, because it will be too simple.
So we will continue to empower our patients,
yeah,
and encourage our parents to take a back seat and let their child fly.
Good advice, really. Okay, so I think we need to call it to a close tonight. Thank you so much to everyone on the panel for answering all these tricky questions and all the advice, and thank you for everyone who's joined tonight. This has been recorded tonight, so it will be available through, I think, probably the press website. And before everyone goes to bed, don't go to bed until you've at least shared lots of Word Day things, tweeted something, you know, keep spreading the words tonight and tomorrow. There's going to be a second webinar on Saturday, and all the information for that is on the press website and on our social media channels. So please join that too. Thanks again, everyone.
Thank you.